Hello friends, welcome to my YouTube channel Normal Lamba. In today's episode, I'll be showing you a medical talk which has been arranged by Indian Lawyer Retired Welfare Association, Delhi NCR with Apollo Hospital, Noida. Subject is Hernias and Gallstones. This talk has been delivered by a leading superspecialist from the Apollo hospitals. So this is going to be very informative and illuminating. Please come with me and watch till end. Thank you very much. God bless you.
And I would like to invite Dr. S.K. Pandita sir and will tell you about the gallbladder and hernias. These are very common in elderly ages. So we'll tell you about the awareness of the gallbladder and hernia disease.
Like gallbladder stones and some hernias in a very short manner. Gallbladder is a very small organ on the underside of the liver. It's actually a storage tank, basically. It releases bile when you need it, usually after once the food goes into your stomach, and it has its own problems. Sometimes the stones form that's called as polylicases, and which usually presents with pain, and some people have dyspepsias, and some people will say that खाना खाने के बाद पेट भारी लगता है, and more complicated patients they usually present with jaundice and cholangitis, pancreatitis. They're complicated cases basically. So in short, usually there are certain predisposing factors for developing gallstones. Usually obese patients, females, highly fertile women, and too much of exercise, too much of protein diet, too much of carbohydrate diet, and sometimes even the bariatric surgery. The obese people, they undergo these bariatric surgeries to reduce the weight. Even they are susceptible to develop these gallstones. Even people who have undergone the resection of small intestines, even they develop gallbladder stones. And usually gallbladder stones, they are either cholesterol gallstones, where cholesterol they form, it combines with the, it forms the crystals and forms the stone in the gallbladder. And there are other kind of stones which are called as pigment gallstones, which usually when the bilirubin that forms the stones. And there are certain drugs even which can lead to gallbladder diseases. There are some diuretics and some estrogen, progesterones, and octreotides which can cause in that area. And it has been seen that any cancer of the gallbladder, we find a stone inside. Usually, clinical features usually presents with pain in the upper abdomen. That's called as biliary colic. It may be for a minute or so. Sometimes it's a prolonged in case the stone gets impacted in the neck, and it's a crampy feeling basically in the abdomen. And episodes last for a few minutes to maybe an hour or so. And if the patients they reach a hospital, get an and get treated. Complicated cases they usually present with jaundice, and that's most often that passage of the gallbladder stone into the common bile duct, where the gallbladder is connected to the common bile duct, and sometimes they present with cholangitis. They will present with fever, jaundice, and pain, and sometimes the gallbladder stones, once they migrate into the common bile duct, they get impacted at the ampulla, at the terminal end of the CBD, common bile duct, what we call, and it leads to pancreatitis. And pancreatitis is a very severe disease. Almost 50% of patients with the pancreatitis, they land up in ICUs. And of these 50% patients having the hemorrhagic pancreatitis, 20% of the patients may die, actually. And that's the so high percentage of the pancreatitis morbidity. So you have to take seriously the gallbladder stones, and almost 50% of the patients, they may not present with any major symptoms. That we usually call asymptomatic patients. Usually patients go for a health check and incidental finding is the gallbladder stone. We usually correlate it with some blood tests, liver function tests. And if the alkaline phosphatase and other enzymes they are raised, we usually go for a magnetic resonance cholangiography, what we call in short term as MRC. And there is one more HIDA scan, and though not done regularly, that's to know the function of the gallbladder. Most of the time, when you have stones in the gallbladder is non-functional actually. And CT abdomen, though not a modality to know the stones in the gallbladder, but in complicated cases where you have pancreatitis, it is the best modality for that. To know the stones, ultrasound is the best modality in the gallbladder, and MRCP, that is the best modality. And of course, the blood test. And now the treatment. Treatment is surgery. You cannot wait for, they usually do, gallbladder stones don't dissolve. Though there have been some theories, some medicines, but usually they are very hectic and the complications are too much. You don't want any gallbladder stones to pass out of the gallbladder, especially into the CVD or into the terminal and leading to pancreatitis, jaundice, cholangitis, and so on. And it has been seen that if the size of the stone is very large, like more than 3 centimeters stone, and if it stays in gallbladder for more than 5 years, the chances of the cancer of the gallbladder are more. So surgery is the best option. पुराने ज़माने में open surgery करते थे. Even I have undergone a open surgery in 19 for the same thing. But आजकल we do laparoscopic surgeries. That's a minimally invasive. It can be done in daycare, but usually we keep patients for 24 hours for management of the pain and other things. Laparoscopy में we just inflate the abdomen with carbon dioxide gas and then place some trocars and hold the gallbladder and just remove it, clip the cystic duct, and you don't disturb the actual anatomy of the CVD. And if you venture into the CVD, that means that you're creating some serious complications. This is like this is a normal anatomy. You can see two ducts, they join, they form a single, that's called common hepatic, and the gallbladder comes, it forms a cystic duct, and that joins the common hepatic called CVD. When we remove that, you can see in the other slide that gallbladder is missing, and this is absolutely normal, and we don't expect any complications in these. But this is a very bad gallbladder, which I had done, I think, a few months back. I think, it's 22 का date लिखा हुआ है इसमें. This is a gangrenous gallbladder. That was the previous slide was a diagrammatic presentation. It doesn't look like exactly the same thing here in the actual surgery. This is the cystic duct which I am touching. You can see the clips down there. That is the cystic artery basically. Usually port infections are they're so not that common, and at least in Apollo I have never encountered any port infections. Biliary duct injury, that CVD duct injury, that's very common, and it's a very bad complication. The implications are very bad. Then you have to open the patient and do a marathon surgery, that's called hepatocortical. And bleeding, sometimes the clips they become loose, and sometimes there are bile leak from the cystic duct. Sometimes there are a lot of stones, multiple stones in the gallbladder, and during surgery they fall in the abdomen and they may be left behind. And the pancreatitis. उसमें से कहीं पे भी कोई वीकनेस हो जाए, उसका सामान बाहर आ जाता है. That's the hernia. So there can be internal hernias which are inside the body, which you cannot see from outside. They are diagnosed on investigation. External, most of the males they have the inguinal hernias. वो नीचे जो होता है दोनों साइड में, just above the organ, male organ, and that's the inguinal hernia. And femoral hernia around the same area, more common in females. Umbilical hernia, जो नाभि जिसको बोलते हैं, तो वहाँ से the intestines, the omentum, it starts to come out. And epigastric hernia ऊपर होता है, just chest के नीचे जो V-shaped area होता है, that's called epigastric region. उसमें hernia. And incisional hernia. Some people who have undergone surgeries, like females, they undergo a hysterectomy, uterus निकालते हैं. So once they close, they somehow develop the weakness in that area and they form the hernia. That's called the incisional hernia. How it presents? It presents like a visible bulge. आपको एक swelling दिखेगी, which may go back of its own. But जैसे आप strain करते हैं या cough करते हैं, it starts to bulge out. And over a period of time, it may not go back. That's called as irreducible hernia. And if you don't get it treated, it may start to pain, it may turn black, and then the complications they happen. That's what is, they usually develop a gangrene. I'll show you a picture which I have done almost a month back. And sometimes these hernias, once the intestine gets obstructed into that, they may develop intestinal obstruction. They will start with vomiting, they may not pass stools or the gas, and they are real emergencies. They are life-saving if you don't treat those patients. And
Surgery is the only answer.
yes, because it's a defect. It's a defect basically. You have to repair the defect with a mesh.
No medication will help.
No medication does help.
Is there any age restriction about the going in for surgery?
No, sir. No, sir. We usually evaluate like the patients of your age. We usually evaluate them for cardiovascular things first. If they are fit for, we have to see the fitness of the patient from the anesthesia point of view. Surgery does not kill the patient. It's the anesthesia that the patient tolerates or not. So we see the fitness of the patients doing stress ecography and other things, ECGs, chest X-rays, seeing the kidney function tests, and many other things. And then patients are taken up for after proper evaluation for the surgery. Though age is not a contraindication for any surgery. And then ultimately they open up the patient and see what exactly is inside. And then if it's infected, we may not put the mesh, we may do the tissue repair. If there are no infections there, and we usually do it with a mesh, what is called as mesh hernioplasty, which can be open as well as laparoscopic. The routine cases, without emergencies, which are cold cases, they are usually done by laparoscopy. But inguinal hernias, I personally prefer open surgeries because complications are less and it's less time consuming. This is one of the, this is the umbilical obstructed hernia. If you can see the, if you can see this is a gangrenous intestine, and rest of this is the gangrenous omentum. And the other side, this is after the resection. I have resected from here and here, and then anastomosed the two ends, and this is the resection anastomos. And patient was almost 74 or 75 years of age, and he did well, but he was in the hospital for 7-8 days because they have to be treated conservatively. You cannot allow them only for 4-5 days till this anastomosis heals. These are the real emergencies. These are life-saving procedures for the patient.